Our final session for the evening is a panel discussion that'll be moderated by Dr. Bill McDade, who's the Chief Diversity and Inclusion Officer at the ACGME, works closely with Dr. Mason, and we're delighted to have him help us here today, along with Elena Rios, who is the President and CEO of the National Hispanic Medical Association, and Dr. Rachel Villanueva, who is the President-elect of the National Medical Association. I think she said as of July, she'll be president. She's also a clinical assistant professor of OBGYN at NYU. And I have sad news to report. Unfortunately, Dr. Winston Wong had a medical emergency and is unable to join us tonight, but I have no doubt that this panel will help really give us some important insights into how we, especially societies, can partner and collectively work towards action with these incredibly important organizations to address equity and anti-racism. So with that, I'm going to turn it to you, Bill, and the panel.
Thanks very much, Dr. Burston. It's a great pleasure to be here with you today, and thank you for asking me to moderate this wonderful group. One of the things that I think is really incredible about today is that the people who've been driving a lot of this work are so dedicated, so passionate about it, and they're people who I've known most of their careers. Dr. Lipson, Dr. Yancey, and now my own Dr. Mason and Dr. Nakai are personal friends as well as leaders in this discipline. And it's great to see the information they've been able to share with everyone today. I think it's fantastic. Well, two more of my friends are here today, Dr. Elena Rios and Dr. Rachel Villanueva. We're going to talk about the relationship that you, as specialty organizations in various disciplines, members of CMSS, have with the national historically underrepresented in medicine groups, National Hispanic Medical Association and the National Medical Association. We are displeased to not have the voice of Asian American Pacific Islander physicians here with us, because Dr. Wong would have done a great job in talking about those issues. And I also make note that we don't have the Association of American Indian Physicians here as well. We have colleagues who have a lot to contribute from that dimension. And if anyone has comments about this that they'd like to put in the chat, we welcome those. Well, for the first thing I'd like to do with Dr. Rios and Dr. Villanueva is just to each spend about maybe 5 or 7 minutes really talking about what your organization is and how it's structured, how it came to be, and what its relationship is with the other umbrella organizations within medicine. Dr. Rios, will you go first?
Sure. And thank you, Dr. Burstein, for having me here. And Bill, it's a pleasure to be with you and Rachel. I just have to say that the National Hispanic Medical Association is the first organization that nationally represented Hispanic physicians. We are the first generation born in this country, raised in this country, that are the alumni of medical schools and undergraduate schools in this country. We do have an international medical graduate section, but that was new to forming probably in the last couple of years. We started the organization. I just have to tell you the brief history because I think it's important for you to realize that we all sit on the backs of leaders from our past. I'm from Los Angeles originally, Mexican American, third generation. My grandparents came after the Mexican Revolution to, working on railroads and to the urban centers and ending up in Los Angeles. Others family histories are with farm workers or with other immigrants looking for jobs. And I'm sure there's a few Hispanics that have been in our countries forever. The land grant families of the Southwest especially, and then of course Puerto Ricans and Dominicans that have been in our country. And we all know that we're part of the indigenous cultures. But anyway, let me tell you, in the 1960s, when affirmative action and financial aid opened up as a result of Dr. Martin Luther King and Bobby Kennedy and others that were, the civil rights movement happened and the anti-Vietnam War happened. The first classes of minority students were allowed into the mainstream colleges in this country. And I realize there's another history with all the African-American colleges too, but I'll just tell you how we came about. The first organization that was created for Hispanic students interested in health was called the National Chicano Health Organization. It was actually started with students who were in public health and undergraduate students like Dr. Robert Montoya and Dr. David Hayes Bautista, Dr. Gilbert Ojeda from California. They created an office in Denver, and they created organizations on the East Coast and the West Coast and in Texas. The importance of that group was that they got an HCOP grant from HRSA to recruit students into medicine and other health careers. And with that grant and with other schools joining in, they were able to find pre-med students. And in California, by the time I started college in the 70s, 1973, there were 25 pre-med clubs in California that were Hispanic. In the 1970s, I was involved with trying to develop recruitment into Stanford University, where I went to college. Actually went to college with Javier Becerra, who's now our Secretary of HHS, and others who have been involved in Washington, D.C. But I think what's important to know is that we all realized, Hispanic students that were involved in these organizing efforts were interested in giving back to their community. So fast forward, I went to public health school, and then I went to medical school. And while at medical school at UCLA in 1982, we started a group of students, probably the largest class of Hispanic students, 21 students at UCLA, who had all been leaders of these pre-med clubs. We started a statewide Hispanic medical student organization called the Chicano Latino Medical Student Association of California. And that turned into a national group. With sharing our bylaws with Chicago, finding the Boricua Health Organization of New York, and working with the Texas group out of San Antonio, because we started a big mentoring program funded by the state, where we mentored and spoke to pre-med students because of all this infrastructure that already existed. So after my residency in internal medicine and after my fellowship, I actually had come to Washington for a few conferences introducing the medical students, which now is called the Latino Medical Student Association, LMSA. And I was asked to work at the White House in 1993 to help find Hispanic health executives and doctors and nurses and others to provide input to the Clinton Healthcare Reform Task Force. In so doing, I was also asked to find 5 Hispanics for every meeting. And in finding Hispanics, I was reaching out to those medical students who are now doctors and others that we met along the way. And that's how we actually had a critical mass of people coming to the White House throughout that year. And by the end of the year, we created the National Hispanic Medical Association. And just to make one point, the word Hispanic was used because the National Association of Hispanic Nurses had started in the 70s, and the Hispanic Dental Association had been started by leaders in the 1980s, the late 80s. So we started in 94, and I'll just say that one of our doctors at the White House became the head of HRSA, and if it wasn't for Dr. Ciro Sumaya and Dr. Joe Ivy Buford, who was the principal deputy assistant secretary, we would not have gotten the support that we did, and the consulting and the guidance on how to start from scratch developing a national organization. And I'll go on later about how we can work together, because we have developed into an organization of, with databases of 50,000 Hispanic doctors, but of course we're trying to be more proactive in getting our membership to be actively nominated and getting involved in advocacy. And our mission has always been to improve the health of Hispanics and other underserved. So, Bill, I'll stop there.
Thanks, Elena. That was fantastic. And in terms of understanding the background of these organizations, when I was a medical student, those are the organizations that were strong, and it was great to see the evolution of the National Hispanic Medical Association. Dr. Villanueva, Rachel, will you give a review of the National Medical Association and its start a few years earlier, back in 1895?
Sure, I'd love to. Thank you so much, and good evening. And I just wanted to really thank CMSS for convening this summit and its commitment to anti-racism, diversity, and equity. It's really such an honor to be part of this esteemed group of colleagues who really are moving the needle in the space of health equity. And I'm grateful to give those of you who may not know about the NMA a little bit of historical background about the NMA. And obviously the racial inequities that exist in our society have been painfully highlighted this past year, and none more significant than that in healthcare. And as we have seen this past year and were so eloquently educated today, the structural racism and pervasive bias that exists in our healthcare system are all implicated in disparate outcomes for communities of color. And I don't think that's really surprising for those of us who advocate for underrepresented physicians and communities that are underserved and under-resourced. And so it's just refreshing and gives me a lot of hope that we have the opportunity to have these type of conversations, and that we do not, as was talked about earlier, we're not afraid to have these conversations, and we're not afraid for our careers to have these conversations. And these disparities that have existed for many, many years are really what fueled the National Medical Association and the birth of the National Medical Association. It was founded in 1895, and it's the nation's oldest and largest scientific and professional organization, representing not only Black physicians, but their patients, which largely still remain the under-resourced and underserved. And the disparities of that time when the NMA was created, and certainly today, are well rooted in the segregation of that time. And so I find it really ironic and actually very sad that in 2021, where on a nightly basis we hear about Jim Crow laws on TV, because it was in the era of the Jim Crow laws and Jim Crow laws now as in reference to voter suppression, because it was at that time that in that era of segregation where everything from housing to education to certainly healthcare was affected and negatively affected communities of color. And at that time, separate certainly did not mean equal, and separate very often really just meant substandard, and particularly in healthcare. And for physicians at that time, they were not allowed to be part of majority societies locally and nationally. And those societies really helped to educate physicians and would help them to get privileges in hospitals. So they were very important. And at that time, physicians of color were not allowed to be part of those organizations. And it was from that the NMA was born. So there were some local physicians who first started to have local societies, and one of the very first was founded in 1884, and that was MedChi in DC. And for those of you who are part of NMA, you know MedChi is one of the most vibrant societies that the NMA has, local societies, and very proud of its heritage. But they knew that at that time those local societies would, and there were ones that were founded across the country. Some of the first ones also were in Atlanta and in North Carolina, Old North State. But they realized that was not going to be enough for taking care of Black physicians and Black communities. And so they came together and formed a national organization. Initially, 12 physicians came together and formed the National Association of Colored Physicians, Dentists, and Pharmacists, because at that time there just weren't enough physicians to make one group. And slowly that group would become the National Medical Association in 1903. And initially it started holding clinics and surgical roundtables at its annual meetings and scientific presentations. And it would soon grow into advocating for better policies for their patients and better health outcomes for their patients, and also for dealing with racism and discrimination for their physicians as they were trying to get positions in hospitals that wouldn't allow them to come in. And so that is the foundation of what the NMA does today. It advocates, and it is the force voice of parity and equity in health for Black physicians. And today we represent over 30,000 Black physicians across the country and in the African diaspora in Africa and in the Caribbean as well. We're committed to advancing clinical and scientific knowledge. We have 26 scientific sections, which align very well with the specialty societies that are represented here. So there's certainly synergy that we see with our society and with CMSS. And I think I just wanted to just talk a little bit about, as Dr. Lipson mentioned, the constructs that have caused some of the inequities that we see currently. And we understand that biases in healthcare affect how patients come to the doctor, whether they come to the doctor, seek treatment, whether they even will, ascribe to the whatever their physician has to, their guidance from that physician. And so we know how important it is to have physicians and healthcare providers that look like the people they're serving. And I think that fact is so important, especially as we talk about medical subspecialties. And we know that communities of color or underrepresented physicians are woefully, numbers are woefully inadequate. And I think that is one of the areas that we hope that we can help improve as we, come together in these important spaces and collaborate. And I just wanted to, I think it was Dr. Yancey who talked about the Flexner Report. And I think we can't underestimate how, even back in 1910, how actually devastating that report was and continues to be for workforce diversity in our country. At that time, there were nearly 14 Black medical colleges that were training Black physicians and caring for Black patients and underserved patients in communities. And after that report that closed, it obviously was not only schools of color that were closed, but it was after that report that only 2 medical schools remain. And that was Howard and Meharry. And I think that just looking at those numbers of physicians that were no longer trained, Black physicians that no longer trained, and we see those numbers still, those numbers are really so shocking still today. I think in 1920, there were 2.5% of physicians were African-American physicians. And today that number is a pitiful 5%. So not that we need justification for meetings such as this or to be able to talk frankly about these issues, but those numbers clearly support the need for what we're doing today. So I really do applaud CMSS for coming together and having this conversation. And I always, when we talk about these issues, I always just want to remind everybody, and I'm sure I'm not saying anything new, but that this is really a journey, that the work is starting. And I'm grateful for that, but it's not going to end with one summit or one workshop or one, priorities on DEI. And although those things are so very important, I think we have to remember that we really have to look critically at everything that we're doing. And we need to make sure that we embed equity in all of the things that we do, because this isn't just an issue about somebody else. This is our issue. It's an all of us issue. It affects our profession. I mean, as Dr. Mason alluded to, we all were trained in these racist systems of healthcare. And I think the ability to be able to say that is incredible. I think too long we blamed patients and race as a reason for the fact that communities of color had high incidences of heart disease or diabetes or cancer. But we know it's not race. We're no longer blaming our patients. We're no longer blaming communities of color. we're going to blame the people that should be blamed and hold those systems accountable. And that's a system that unfortunately we all are a part of. And I think recognizing that we are a part of these systems, it just adds my passion for making sure that we dismantle these systems, that we all work together and we come together and collaborate. So I'm just so grateful for the opportunity today to talk a little bit about how important the NMA is historically, how very important the NMA is to me, obviously. I really look forward as president to be able to work with all of the specialty societies. I think there's so many areas for us to align and so many areas of synergy. And I just really thank you for the opportunity tonight.
Well, thanks, Rachel. And that was really a great overview of the National Medical Association in the early years of medicine and the importance of the Flexner Report. One of the questions that I wanted to put before you as leaders of a national organization now in communication with specialty organizations is, what do you think the role of specialty organizations or the medical specialties is to a diverse community? I mean, we hear a lot of emphasis placed on primary care. Do the specialties have a role in order to produce a workforce that will treat underserved populations too? Dr. Rios?
Yes, definitely. I think we need specialties to help educate our patients about the nuances of disease as they go from a primary care doctor, for example, with diabetes, to the ophthalmologist, to the neurologist, to everybody else, the cardiologist, et cetera. And I think that the team approach to our communities is very important, as well as the patient-centered and cultural competence approach to the continuum of care, going from a hospital to rehab to home health care, and probably more home health care in the future is going to be needed. And all of that is going to need the continued teamwork with the specialties. And just as an example, and I know that Rachel, you mentioned the importance of specialties within the NMA. The NHMA has just decided to move forward on developing sections within the National Hispanic Medical Association that would be specialties. We have worked with the ACP, the AAP, and the AAFP, and of course the AAMC, and some of the osteopathic schools. And we have worked individually with medical schools as institutional membership that we have, but it's been primarily at the local level. And we think that at the national level, it is very important to meet with leadership on how we can help each other. Our students are very interested in specialties. I think there's been a trend in moving toward, following your dreams, but also in reality, there's been a lot more debt with our students in the generation that we've had. We've had 25 years of an NHMA and seen the generation change. And I think that the specialties offer something very, very important, which is leadership and mentorship within the specialties to the diverse students. And Latino students are very interested in having us find more specialists to be speakers. We have an NHMA liaison program with medical schools where there are Hispanic students. We only have about 25 of them right now. The Hispanic medical students have about 130 chapters now. So there's 130 medical schools in this country that already are linked to our organizations, but we're not linked to the specialties outside of the primary care groups. And I think the other way we can help each other is with identifying doctors from our community. We have a membership, an active membership, and we ask if anyone would like to be nominated for opportunities that come our way. Every Friday we send out nominations. And if any of the specialty societies would like to have more diverse committees in your organizations, we're more than happy to nominate people because it provides them with an opportunity for promotions if they're faculty or learning experiences. And also, I think it's important to diversify the people at the table in your committees, as well as we'd like to be able to find more speakers that are expert from your organizations at our national conference and our chapters that we have around. We have about 20 chapters around the country very interested in developing their own speakers for educational purposes. So anyway, a lot to do, Bill.
Yeah. So I heard maybe at least 2 or 3 asks in that one for when you're thinking about a speaker that they can refer to you, that you're getting ready to develop, or you're in the process of developing specialty sections within NHMA, and then that when you're looking for committee service within the specialty organizations, they can turn to you as a resource to help to try to refer physicians. Those are 3 important asks of the specialty societies. Dr. Villanueva, are there 3 asks that you think the National Medical Association has?
300? No. No. No, I think with Dr. Rios, her points were excellent and align with what NMA would also want. I think, you know, one of the I think most important things I think I would love for all of the societies to really do is really look at their own societies first, right? And really look at your leadership, your staff. Is there diversity? Is there the diversity in those areas that you are asked that we're talking about today? I mean, I think the societies really have probably work to do on their own in addressing diversity in their own societies themselves. And I think that's really important because I think, as we know, representation matters. And I think if we don't see the leadership down to the staff, top to bottom, representative of diversity, then it definitely falls short what we're doing. I think it's really important for us, as my good friend, Dr. Mason mentioned, that when we're looking at applicants, we look at the whole applicant, that holistic view of the applicant, that we're not using some arbitrary cutoff and focusing on one point to really decide whether or not we'll take somebody into a residency program or fellowship. I think when she referred to the fact that some places don't even consider or won't really consider applicants from HBCUs, they're leaving talent on the table. And I love that saying, so I am going to steal it. I'm sorry. But I think that is really important for the members of the societies at their own institutions. What are your institutions doing? What are the policies? How are you engaging your department in your equity and diversity process? Is it just a statement, or is there actually some meat on those bones? And I think that's really important because we won't have any diversity in specialties if we don't start from that process with GME and fellowship.
One of the exciting new developments in U.S. Diversity measures has been at Oklahoma State, where the school is focused on increasing the number of Native American Indian physicians. We actually have 2 members on our ACGME board who are associated with Oklahoma State. And it's very exciting to see the numbers of underrepresented minorities in general, but from the Native American community go up, since it was so much ravaged by COVID. If you look at the data with respect to indigenous populations, how have the historically Black colleges and historically Black graduate research institutions played a role? And I'll go to Rachel back with this one, in the National Medical Association, and I'm going to come to you with the Hispanic Serving Institutions and Dr. Rios in a second. What kind of role do they play, and how can the specialty organizations be involved in helping to drive the efforts that these institutions serve to increase the number of underrepresented minorities? Clyde Yancey said in his talk that if there were a 5th historically Black medical school, it would make a dramatic difference in the number of African-American physicians trained, for instance.
Oh, absolutely. I was in my office screaming with my hands up in the air when he said that. I think partnerships with his HBCU medical schools are critical. I think the pipeline should start obviously way before that, but there should be active pipelines with the specialty sections and the HBCUs. I think it's critical it's critical to not underestimate the talent that comes from HBCUs. And so I think if the specialty societies are willing, and I think that's obvious by this engagement tonight, it's really opening that dialogue. And obviously NMA is at the center of that, but I think it's opening the dialogue and opening their doors and opening their minds to the fact that it doesn't have to be an Ivy League graduate to have an excellent physician. We know that. Yes.
One of the things that we've noticed at ACGME is just the small numbers of individuals, and you see the actual numbers in individual specialties and subspecialties. And it often surprises audiences that I present the data to of how few there are. I mean, if I look at my own discipline in anesthesia, in a year like last year with COVID, there are only 16 African-American critical care fellows in the country. And the number for internal medicine is only about 17 or 18. For Latinx individuals, it's not much higher than that. And so if you think about the importance of specialty work in society, you can't exclude minority communities, underrepresented minorities. Dr. Rios, what about the Hispanic serving institutions?
Well, I have to tell you that NHMA has developed, through a grant with the Office of Minority Health, our own NHMA College Health Scholars Program. And we are partnering with, in Southern California and in San Antonio, UCLA, USC, UC Riverside, Drew, and in San Antonio, the Incarnate Word University, and that just started an osteopathic medical school, and UT Health Science Center, San Antonio. And then we have our Washington, DC is the area where we have our national conference. So with those three areas, kind of capturing the East Coast, Texas, and California, we've recruited over 2,000 pre-med students, mainly pre-med, but the group was recruiting for 5 different groups: pre-dental, pre-medical, pre-nursing, pre-public health, and graduate science. And I have to say that the Hispanic serving institutions have sent their advisors, their students have come to our conferences. And this year we had to change it to virtual, but we did have 600 students that applied. So there's a void, there's a real need for not only partnership, but partnership with schools that are in the profession, the pre-med or the medical schools, but with the community colleges and with the colleges that are not HSIs. There are a lot of Hispanic serving institutions, but they're mainly low financed institutions that don't have NIH research grants, and they don't have medical schools. Very few have any type of medical schools, except for the Puerto Rican schools. And then I think there may be one UC, University of California, and San Antonio may be one also. But for the most part, the HSIs aren't the schools that we think of as comparable to the HBCUs. It's the Hispanic serving health profession schools that were created by Secretary Shalala and the Hispanic Agenda for Action of the Clinton administration. That organization mirrors the AMPS group, the Association of Minority Health Profession Schools. This one, the Hispanic Serving Health Profession Schools, decided to have medical schools and public health schools with a 9% Hispanic student enrollment to be eligible to join together. And I actually worked for them in the 90s and developed an internship program with CDC so that students could have the opportunity to learn about prevention, public health research. But I think that moving forward, the opportunity is for students in colleges to be mentored by the medical students, and medical students to be mentored by residents, residents to be mentored by young physicians. And in fact, that's how we've developed our organization with these different levels: Council of Young Physicians, Council of Residents, and now the College Health Scholars Program, and the medical students also involved as our mentors for the pre-med. In working with the medical societies, the organizations of medical societies, it's really the resident level. It's having the medical societies that are interested in thinking out of the box and diversifying. I think we could be a link to residents. We have a council of residents that are very interested in having more connections to the specialty societies. They come to it. We have our conference with speakers, but we also have chapters that have steering committees made up of the young physicians, the residents, and the medical students. And there's no reason why we can't connect at a regional level or a national level, and lots of opportunities to connect, Bill. And with the HSIs, I think we just have to bring them along. I've met with the National Association of Healthcare Advisors, and they are really interested in figuring out how to help us with diversifying the Hispanic students. The pool is out there. They've just never heard from us. And we're, the alumni of the medical schools have not been engaged in getting to the pre-meds and as mentors. They're not sons and daughters of doctors, and they're first generation students who have no clue what to do. So they're very interested in getting engaged.
Oh, that's amazing. One of the things that I thought about in this past year where we were impacted by COVID, where fourth year medical students weren't able to do away rotations because of the COVID concerns, where people weren't able to do to attend national meetings to recruit underrepresented minority students at the LMSA annual meeting and at the Student National Medical Association annual meeting. What I found when I attended the National Medical Association in the anesthesiology section is we had a number of chairs of departments who came to that meeting, and we actually had a student research symposium. Is that a possibility? Could we get all the specialty societies to work with the National Medical Association, National Hispanic Medical Association, in order to have them attend maybe the medical student research symposia that you host within your sections at your organization? Rachel, do you have comments?
Absolutely. I mean, no, absolutely. I think that would be, I think that would be, an excellent idea. I mean, I think the wealth of leadership that you find at NMA scientific sections, program chairs, chairs of departments. I think, the mentorship that students get there is invaluable. But I think partnership with the scientific societies would be also, it would be excellent. I think it would be nice as well. I was thinking as you were speaking to have really a plan from the scientific societies. What would they like their specialty to look like as far as diversity in the future? Let's make it actionable. Let's have some metrics. Let's not just partner. Let's say that we'd like to see an increase in the number of critical care fellows in anesthesia that are underrepresented minorities by a certain time in a certain year. I think those type of concrete plans are really important. We have almost all of the scientific sections have some type of poster presentation for not only residents and fellows, but medical students as well. So I think that's easy. That's not the tough ask. I think the tough ask is really how do we work to get the numbers of underrepresented minorities increased in the specialty sections? Is there room for NMA leadership to be at the table? I know, I'm a member of ACOG, and ACOG has a partnership and has leadership that from NMA that's leadership in ACOG as well. So I think, I think those things are really important as far as the leadership and as far as the decision-making processes and are we involved in those things? And I think that's where I'd also like to see a good partnership.
Elena, how about, should we have the specialty societies attend symposia at National Medical Association as well, National Hispanic Medical Association?
Oh, definitely. Our next conference will be our 25th annual conference, and we're already planning and have thought about just going ahead and keeping it in DC maybe one more year. I don't know how many years we've had it in DC, but we are very interested in having the development of the sections with societies. And we'll have to start small. Like I said, ACP, AAP, AFP, we've already enjoyed working relationships with, but I think that, we've already touched bases with cardiologists and endocrinologists and others as speakers, and we certainly enjoy a more formal relationship. We do have an institutional membership. That might be a way to expand our reach to the specialty societies. The other thing is the sections, though, I think. And like Rachel said, we have to get the medical students more involved at our conference. And that's something that they have asked us to do, is to help them with understanding how to get into specialties. And yes, and the match is another big issue. And I think it helps to know people. Relationships are always key. Also to do away rotations within the specialties. So there are things that we can plan ahead of time for our students and to, to increase the residents' diversity as well as the faculty diversity. I think that's important. And then I guess the last thing I would say is that we're very interested in having leadership training. We have an NHMA Leadership Fellowship that we started with the Clinton administration, Obama administration. We're restarting it now with our CDC grant for COVID-19. And we realize how important it is to train physicians on public health activities, to be leaders within whether it's academic or private sector organizations, that they understand the importance of working with different stakeholders. And that's what our leadership is all about. And working with specialty societies would definitely bring us a wealth of leaders.
Oh, that's excellent. I noticed that there's one question in the chat. Please put questions in the chat for these two amazing leaders. There's a question here that refers to something that you touched on a bit, Elena, and that residents were very involved in the National Medical Association, in the National Hispanic Medical Association, and this question asks, ACGME should take a role in supporting people of color who are experiencing racism and women who are experiencing sexism in their programs, because many are coerced or mishandled in their programs. ACGME certainly has program requirements that are around a responsibility of a program director to allow residents to give feedback without fear of retaliation and intimidation. But I think there are people who feel obviously that that's insufficient, that ACGME can't protect them and so don't report. How might the specialty societies and the national minority societies come into play to help residents who are in danger of being either terminated or dismissed or disciplined in ways that are based in racism or based in injustice?
I mean, I think that issue is obviously something that transcends just race, right? We deal with that on a sexual orientation level, sex. The NMA has very often, and probably more often than we'd like to, has supported local, I'm sorry, this is the New York sirens that you're hearing, so I apologize for that, but has often supported residents, have supported medical students, attendings, local physicians in local, in locales with their their state societies. I think we play a critical role, but I think it's really important for us really to work as a collaborative. And I think the specialty sections would really play an important role with that. I don't know about, I'm not sure, I don't know if I want to get into too many specifics, but I do think that collaborating more to have a united front for any individual that's being subjected to racist behavior, sexist behavior, what have you. I think it really is important that there is a strong front from not only medical societies such as the NMA, but the specialty societies as well. These obviously is an area that we could partner together in being very forceful with programs and hospitals. I mean, many hospital systems some don't even have anti-racist policies, like what happens if something is brought up, if something's brought up by a patient. And I think that's a piece that we often forget is advocating for our patients in these situations. So Elena, if you have any other thoughts.
Well, I just think that I think it would be nice to have some type of a ombudsman approach. So when you're in college or in medical school, institutions have ombudsman offices that allow two sides of the story to be told, I guess like a trial, but not necessarily a trial, more of a fact finding and having, there's always two sides to a story, and people may be racist because they're ignorant. People may be racist because they're just, it may be important to show them that with research, that they may have treated somebody totally different than somebody else or other. And a lot of people that are caught in those types of activities deny. So you need to have some way of having the evidence be shown and discussed to an objective observer, which is what the ombudsman approach is all about. And I think that would be the way to handle it. Though maybe through the ACGME policies, there could be a layer that is more objective, that outside of the institution itself.
Well, we do have a complaints and concerns function there where people can bring violations of ACGME common program requirements. And we do have a new program requirement, the requirement 6B6, that says that all residency programs in partnership with their sponsoring institutions must engage in a practice of professionalism, non-discrimination, civility, and lack of harassment, mistreatment, coercion, and sexual harassment and other forms of harassment. So to bring those complaints to the ACGME, it would be a fabulous thing for residents to know about and to exercise. But they've got to feel comfortable, they got to feel supported, and I think the community of the specialties is really where that might come from. I mean,
unfortunately, I just wanted to say, unfortunately, I've heard of cases, for example, that are that go straight to lawyers and have legal arguments brought up that last for years, and it's unfair. I mean, I'm just to the system, because you lose a good doctor and his career stopped because they're caught up in litigation, and usually what happens is the institutions win. The institutions just fire them.
And as you point out,
and then
so
they
expensive.
continue to have the legal, to have to pay the legal fees.
Right. You point out a perfect thing, that it's so expensive and people already have tremendous debt upon them. Well, we're running short on time. We may only have a question or two left at this point. One of the things that I think is also important with respect to increasing the awareness of specialties about the diversity that exists within their own specialty is seeing data. Are there any data elements that you'd like to see specialty organizations collect of any sort that might help to fuel your understanding of the status of the profession at this point? Or do you have a pretty good lock on that already? If you wanted to share data or exchange information somehow with the specialty organizations, is that something that you'd be open to?
I think the biggest data that we need right now is and I don't know the exact variables, but I think we need to show the federal government how important it is to increase the number of GME slots in this country. And I would hope that that would be the focus of the only way we're going to increase the opportunities for diverse students to get into these very, very competitive specialties is to increase the slots. And I think that that has to happen. And so that would be my wish list for data would be how many people do not match in a discipline and how many of them were Hispanic or Black. And if there were more slots, you know, maybe they would have a better chance. And I guess the other data would be how many Black and Hispanic students, Native American students, don't make it through the residency programs, the retention issue. Because we can increase the pipeline, but if there's a problem with retention, then we've got to work on both. And that's where the specialty residency programs come in. And then the faculty. We already know that we're, you know, way below the 8 ball with numbers of in the faculty. But I mean, I don't know. The other wish list I would have, and I don't think it's a data collection, but it's a advocacy issue, is to have a Hispanic medical school that becomes as powerful as the historically Black colleges, because we've never had one on the mainland, in one of our large states with so many Hispanic populations, to show the major impact that could happen if there was leadership and faculty involved and really focused on a community that is totally marginalized in this country.
Well, Rachel, I'll give you the last word on that. Is there any data that you'd like to see from the NRMA perspective on from the specialty societies that could be shared?
From the specialty societies, I think the data that I'd like to see is, I mean, unfortunately, we know the data is not very good currently, but what we're going to do to improve that data. That's really what I would like to see, more than specific data points, because we kind of know what those are, and they're pretty poor across the board, and haven't not increased in 10+ years. So I would really more like to look at what concrete action, what plan that the specialty societies want to take, what steps they'll take to improve the numbers of underrepresented minorities in their specialties. How are they going to improve that? Not only that, but how will they improve leadership positions within their own specialty societies? How will they increase those numbers? What are their steps to improve career development and advancement within the specialties? Who's on their editorial boards? Who's making the decisions? I mean, just I think it was Dr. Lipson was referring to, you know, those things are so important. I mean, we can talk about, you know, we can talk about, we just can't talk about things in a vacuum. So I think it has to be widespread. It has to be across the board, soup to nuts, top down. How are we going to improve underrepresented minorities in our specialty societies? How are we going to improve the numbers of medical students going into these specialties? And I think that's really where I'd like to put my efforts. What kind of strategic plan are we going to have for the next, you know, short term and the long term?
Well, I know with your guidance, we'll make a major dent in that. Dr. Burston, I'm going to have you close out the program. Thank you very much. This has been quite an afternoon. The hour has flown by.
Yes, I just want to thank all three of you. What a remarkable session. My hand is cramping from the number of asks. So thank you. Keep them coming. And I think you're absolutely right. There are huge opportunities here for us to work together. And I think your last comment, Dr. Villanueva, really resonates around having the right data and the right metrics to demonstrate our progress. Thank you, Dr. McDade, for moderating a great session. Sorry we couldn't have Dr. Wong with us today, and we wish him well. I just want to quickly turn to Dr. Darylyn Moyer, who's our current president of CMSS, as well as the EVP and CEO of ACP, to close us out. Darylyn.
I want to thank everyone for a phenomenal program. My phone was on fire with the number of texts that I got during this program. I really do see this as the first big step on a journey that our energized village needs to take together. CMSS, with 45 specialty societies and representing over 800,000 practicing physicians, is very much, has a lot of skin in the game here. And I don't want to misappropriate this comment because I'm sure it's been misappropriated, but vision without execution is hallucination. I believe that we are at the tipping point now, and I see the synergy, the energy, and this is the first step on that journey. And we are going to have many of these sessions to follow. We are going to take all of those important words of wisdom that you left us with, and we are going to work together for once and for all to get this done.
Yes.
Thank you.
Thank you all. Have a wonderful night, and thank you for joining us, and look forward to sharing the recording and the slides with you to follow. Thanks again. Good night.
Good night.